So this is just to let you know that you're in the right place. And today I'm going to talk about clots that sometimes complicate Achilles rupture, and you can see a bunch of clots here. So why is the problem? But since the answer to that is not always obvious, I'd like to talk perhaps with different questions in mind. What, when, where, and to whom does it happen? So this is my disclosure slide. I didn't get any money either. So essentially, I'd like to tell you why I did this. So, yeah, as Salim mentioned, when I returned to medicine after a little absence, I gained a very strong impression from one patient who I like to think of as my first patient, not quite, of course, but and thereafter, because I was delighted at my ability after returning to medicine to be able to treat this patient and to diagnose this patient, it became salient for me during my subsequent practice. I noticed people with the condition of Achilles rupture and I began to wonder about it. And this slide shows you the tool that I use to plan my PDP, which I suggest that if you're not familiar with, you should become so. And as part of that PDP, I developed a goal called research, and if you look at the bottom goal there in detail, you'll see that it actually amounts to what am I going to do? I'm going to deliver a Goodfellow presentation on DVT and hi. So aside from the app being jolly useful, it does actually have some personality, so it's not completely perfect. But I'd still recognise that it has some value for me in any case. So as for why research is a goal, I felt that I should do something useful with my spare time that I'd perhaps like to give back to the medical community. And I thought there might be an opportunity to improve patient outcomes, but really, if I'm honest, my main motivation is I'm simply curious. I wanted to know how many of the patients coming through our clinic had this condition and what happened afterwards or what complications ensued. And consistent with my consistency and commitment bias, one of the 24 standard causes of human misjudgment, as talked about by this man on the left, I'm giving this talk today. So the pros and cons of this particular piece of research are that it seemed to me that the data was available. There wasn't really any red tape stopping me doing the research because I was the one doing it, and it looked like it would be possible to find enough numbers to provide useful outcomes. On the downside there, it's always going to be a retrospective information, and I just wondered if maybe we were only going to find incidence numbers and it wouldn't be very interesting. I think it is slightly interesting, hence why I'm here. The inclusion criteria for the study was those patients who were available in those years, 1 March 2014, 30 September 16, around when the study was conceived, with a clinical or an ultrasound diagnosis of Achilles rupture, either partial or complete, and at least 1 week of cast immobilisation with deference to previous studies, as that was close to their inclusion criteria. And I wondered if there were enough patients. So it turns out that over that time frame, we had 411 occurrences where there was a diagnostic criteria of Achilles rupture. And another point which I discovered and didn't really expect, although in reflection perhaps I should have, is that the diagnosis is not certain. And the way it's done with ACC is you guess, you submit the claim, and maybe that changes later on. So in fact, it's not a bad guess most of the time. Roughly 3/4 of the time, the diagnosis turns out to be accurate. In any case, 100 didn't have an Achilles rupture. 17 excused themselves by getting an open repair for various reasons, although we know that that's equivalent in terms of outcome to conservative management. 7 were lost to follow-up, went overseas, went to another DHB jurisdiction, and I couldn't be bothered driving to Hamilton to get the notes. 3 had insufficient information, so the notes just were minimal. And 1 actually oddly declined treatment. This was an older chap who, I guess, limped away. So the basic analysis is that we had 283 patients with Achilles rupture at an average age of 41, and there were more men. So watch out if you're a 41-year-old bloke playing squash. But then the question arises, why does this actually happen? Pardon the cat, it's the world of the internet, so you can see the cat again. It turns out that the proximate causes are netball, rugby, soccer, touch, basketball, don't know, badminton, I fell, running, step, jump, tennis, fall, volleyball, and you're not safe if you're watching sport either. This is a 40-year-old woman who was watching her daughter play netball. The ball came off the court, she caught it, stumbled back, and then turned up to our place. She didn't get a DVT, as it turns out. So you'll notice a common theme here. We're a sport-mad nation. And so I looked into this a little further. So pardon the assumptions. I simply made a judgment call on some of these. So I couldn't tell you, for example, whether the person who was dancing was actually involved in some kind of competitive sport, so I made a guess sometimes. And, you know, is running a sport if it's marathon running, or is it a sport if you're taking the dog for a run? Not sure, but there weren't that many of those. Interestingly, however, what I was able to do was something equivalent to what you see here. This is from Finland in the 1970s. Thank you to my Scandinavian friends who divided the TA occurrences into sport and non-sport related, and of course sports related injuries occur earlier in life, and TA ruptures from other causes progress through one's entire life, but end at a somewhat lower rate. So it would seem to be sport related. The nearest I could get, and I should point out that these are incidence figures, because in Scandinavia apparently it's easier to get your study done across an entire geographic region. I was unable to do that incidence figure, but I've got occurrence data. So on the left there, on the axis, there's tendo Achilles events, and the blue are sport related and the red non-sport related. So it's roughly the same. I actually didn't expect that going in. The peak occurrences are both earlier and later than I'd expected. But in any case, we're sports mad, and that's the proximate cause. So now to the main complication, and this is what really interested me. People come to us with a problem. We don't go looking for DVT. They only turn up when they've got some pain or something, they've noticed their toe's gone blue or some such thing. And I suspect that different demographics have different rates of complaint. And I'll talk a bit more about that later. But anyway, they come to us because they're symptomatic, they complain, and then we find it. And we find it on ultrasound. So of those 283 DVT TA occurrences, of course the vast majority were non-DVT, 27 occurrences of deep vein thrombosis that we were able to demonstrate, and we didn't go looking for it. These are people coming to us. So that's 9% roughly, which is higher than I had thought, and is higher than, for example, Braithwaite discovered in the cohort in Wellington. Not sure why that is, but those are the facts. Interestingly, there is an equal split men and women, despite that men get more ruptured Achilles. So maybe being female is an independent risk factor. Maybe, I'm just not sure, but it's interesting. Those are simply the facts, remember. As for when it occurs, one of those W questions, it would seem to occur mostly early, so there's a peak, not immediately, but a few days after. By the way, on the x-axis, that is days from occurrence of Achilles rupture. And there's also a bit of a late tail that tapers off towards the end of their confinement in the cast. again, interesting, I think. The reasons for this are not that cryptic, and the causes were well known quite early, and the first record I found of this was Virchow's triad. Never mind the small print there, but it turns out Virchow did a whole lot of other jolly good stuff for medicine. In any case, I thought I'd honour him by having his picture. So the risk factors that we know of, and there are others of course, but maybe female based on this, maybe pregnancy, malignancy, obesity, previous history of VTE, other conditions, and maybe just thinking about that traffic, maybe Aucklanders just spend more time in traffic. Maybe that's why they have more DVTs. Or maybe we're just a bit more complainy than the Wellington people, and our people with casts just turn up more often because, you know, they don't like having pain. So the question, I think, at this point, and this is my subtext really, and what to do on Monday, because that's the theme, is consider doing research, because this didn't take me a lot of time, and it's easy to do research based on a look at the notes. And at White Cross, I'm in a position where I can look at the general practice notes and do retrospective studies. I think anyone else in White Cross could do the same thing if they had in mind. So it actually didn't take a lot of time to do this, and there's a small contribution to human knowledge in doing it. But essentially the question I think I'd like to pose is that now we know that low-dose aspirin is ineffective. Is there something else that we should be doing to address the occurrence of DVT in our patients with ruptured Achilles tendon? So thank you to my friends at White Cross who provided access to the information, and to those at Shawcare who also provided access to their notes. And really that's a nice little short romp through my wee study on DVT and Achilles. So we'll be joined by Nicola, a colleague from Auckland Hospital, and I would like you to ask any questions that occur to you on the treatment of thrombosis. So that would be the second part of the talk, and don't necessarily address your questions to me. Nicola, come up and join us. So if anybody's got any questions about the treatment of thrombosis. Yes. Right, so the question is what's the treatment for the people in my study? And the answer is it varies, and it seems to vary depending on which orthopaedic surgeon they saw. So, for example, the initial treating physician would invariably put these patients in a cast. So they then turn up to a follow-up clinic at some time, at 10 days, 2 weeks often. Whereupon the orthopaedic surgeon does what he's been doing for his whole life, and that varies a lot. So some go into a moon boot with a heel raise at that point, some go into a cast for another 3 weeks and then go into a moon boot, and some go into a range walker, which I've never actually physically seen, but they do exist, I'm told, and some go to early mobilisation. Some orthopaedic surgeons use what I'll refer to as the Twaddle protocol, which my colleague Bruce Twaddle developed, orthopaedic surgeon, but most don't. So it varies a lot, but which is why my inclusion criteria of 1 week in a cast. Yeah. Mm-hmm. Yeah, so 100, why 100 misdiagnoses? Well, it's my humble opinion, it's partly due to the way that ACC forms work in our electronic health system. When the patient comes in, you're required to apply a diagnosis on presentation, so you just guess. Based on your best guess, you might be wrong. and subsequently they didn't have one, which you find out by, say, ultrasound, or they walk out. So yeah, what surprised me is how accurate it was. So, sorry, what's your question?
So most of these patients who didn't want ultrasound anyway, right, for the original diagnosis of a structure, so it was most of those clinical anyway, so by that stage it was very long. I guess, so at the point when you had chosen your patients, are they after they were seen by specialists, or would that happen prior to individual care of the patient?
Okay, so prior to the 100 being rejected, if you like, the patients came through this, so the query was ever diagnosed with Achilles rupture. So that was the query term that we used against the database. Yeah. And in terms of the ultrasound or clinical diagnosis, I didn't look into that. But my feeling is that about a third had the diagnosis made by ultrasound ultimately. I think, but I will, when I've been told to publish this, and I will publish that thing. Yeah. Uh-huh.
Were they big DVTs or small, below knee, above knee? Really different?
Yeah, interesting question. And again, I didn't have the time to look into that, but I will publish that. I don't know, but Nicola might have a view from her data set, actually.
Yeah, look, this is just, obviously, we don't actually diagnose the DVTs at the thrombosis unit. They're diagnosed either in the community by the GP or urgent care or an orthopaedic surgeon occasionally. And most of them are small. And that was the only other thing I was going to comment on. We regard the muscular vein thromboses, which you often see quite like the medial gastroc ones, as not DVTs. And I think that would be very interesting to look at, and it might actually change your numbers slightly. I can safely say, yeah, most of them, looking back, are distal, below the trifurcation. Occasionally we get a very low proximal, but thinking back, and I've been doing this for about 8 years or so, I can't think of a major proximal DVT secondary to this.
We didn't find anyone admitted to hospital with a PE in this data set. The question is, would we see the same thing with other injuries where there's immobilisation? And in fact, yes, you do. It's not a phenomena exclusive to the type of injury that I'm looking at, but rather prompted by immobilisation. And if I recall correctly, if immobilisation is a sole factor, that provides a relative increased risk of nearly 70 times. So you have a 70 times, roughly 70 times increased risk of DVT on below knee cast application.
So it's just like it's not the muscle from the
Yeah, I think there are a couple of factors, aren't there, with Achilles? The muscles all squinched up presumably as well, and the posture's odd, and you've got this immobilisation.
Inflammation as well.
Right.
Yeah. I mean, just commenting on Stuart's thing, our Bible that we go by is the ACCP guidelines, which is the American College of Chest Physicians, which you can get online, and it basically is a very evidence-based thing, looking at how you treat DVT and prevent it as well. And before I came, I actually looked up whether you should, they sort of call it any lower leg injury, whether you should prophylax that, because that's what we're talking about here. And in fact, the data is pretty scanty from what they say. At the moment, they say you shouldn't, but that they fully acknowledge the fact that what they've got to deal with is very low-grade evidence, and I think any trial is going to be helpful. They've only used low molecular weight heparin, and there's been a little bit of aspirin stuff. Don't get me started on aspirin prophylaxis, but and there's nothing on these newer drugs, and I think that would be very interesting actually to look at. And I think that's kind of where Stuart's going down, not the low molecular weight heparin side of it. I think the trials that they have got saying if you give them low molecular weight heparin, you have to treat sort of one in about, I think it was something like 7,000 to make a difference. You know, but the trials are just terrible, really. But they've got to work with.
I'm sorry, this is something.
Oh.
Question, Stuart, I don't know if that's relevant or not, but I'm just curious as to that. When you actually see the patient for the first time, and there is a suspicion of an Achilles injury, and whether it be moderate or apparent or severe in appearance, is it at that time, let's say it's after hours or it's after 6 o'clock, or after where you can, let's say realistically, get an urgent ultrasound to verify the degree of and or the extent of the injury. Is it reasonable to have an ultrasound following day whereby I guess I would describe it as a front slab decline or a window cast where the area would be exposed to either verify or quantify the degree of injury? Would that have an effect upon the significance or the urgency of referral? Because that's the second half of the question. Is an ultrasound recommended regardless of what you think clinically it's indicated or not? And then if so, within 24 hours? And
Well, I guess the question is an ultrasound indicated? You know, in my practice, I would not do an ultrasound routinely unless I thought there was other pathology or I was uncertain of the diagnosis. And I don't know what the practice is for the orthopaedic surgeons who receive my referrals, but I note that many do ultrasounds. I think it's largely a clinical diagnosis. I will get my patients to kneel on a chair and squeeze the calf, and if nobody's home, they've got an Achilles rupture. I think the clinical diagnosis is pretty good, but I would be interested to hear anyone's opinion on that. So I don't routinely refer for ultrasound.
so the second half of that question is, if you were unsure as to the degree, would it make any difference in the urgency of the referral if it were a complete sever versus partial?
I refer everyone with this injury, and I put a cast on straight away unless there's a reason not to.
Can I add something?
I mean, the urgency would be based on whether or not they needed, because it's generally, 10 days to 2 weeks, they would follow up. If it were a complete sever, would that time frame change?
No.
Can I just add something? We've had a number of orthopedics in our world. We've had a number of clinics, and the majority of the orthopedic surgeons that are at the clinics, who do the clinics in White Cross, they advise that they don't want any ultrasound stuff. So basically, all of them have said, if you have any suspicion for a Achilles tendon rupture, like when the Thompson test, and so if there is little to no movement in when the Thompson test, then you put them in a cast regardless, and you refer to them. So if you did any ultrasounds, a lot of them are very against it, and there's like former orthopedic surgeons, some of them that I've spoken to, they're very against it.
I'd like to comment on the Achilles tendon rupture. It's a clinical diagnosis. If the test is showing no movement, it's always an Achilles rupture. Most of the errors occur when you assume it's a partial tear. The reason for operating are delayed presentations, so you can force an operation if you don't treat it as an Achilles rupture. The tests are very inconclusive. The clinical diagnosis is really good. So if there's a gap and the Thompson's test, if you're going to call it Thompson's, you can choose which name you want to use. If it suggests it's ruptured, it's always ruptured. And there's a debate between Thompson and other. I did a blog on this that, we don't know which guy invented the test first. Who cares? If there's no movement on squeeze, the tendon is always ruptured. The most Errors that occur in Achilles tendon rupture occur when you assume it's a partial tear. If it's obviously a calf tear, medial gastroc tear, it's going to appear completely different. It's going to be tender very different. But most errors occur when you assume it's a partial tear.
Interestingly, if I might just follow up on that, in this series there were no diagnostic errors that I uncovered. The delayed, other than the 100 who weren't, the people who had an Achilles were treated appropriately, is what I meant to say. Excuse me. English is a second language. So they all seem to be treated appropriately. The causes of delayed presentation were patient-generated. So people were walking 5 days later saying, I still can't walk properly. That was the reason for surgical intervention in the vast majority of cases. So.
I'm from Dunedin, and we do a third test for an Achilles tendon. We do the Clots test. We do palpation for the gap. We do that twice, once down the side and then once running down the back, single finger, and also it'll give you a point of tenderness. But we get them fully prone. If you look at them from the side, if there's a rupture, the foot will hang vertically because it's got no hold on it. The foot hangs completely vertically, and that's definitely a rupture.
Right.
You can't do that otherwise. You have to actually pull it up with your anterior muscle otherwise.
Right.
So that we found that's very good. But in Dunedin, the surgeons won't touch them at all. They won't do surgery on them unless you're at all that.
Sure. And that seems to be entirely appropriate and consistent with the findings of Poon and Twaddle study, that the outcome's the same for conservative management when compared with surgical intervention.
So if someone's predisposed to DVT, just for previous DVT, do you recommend them help someone with Flexin or
Ooh.
It's all right, these are my phone calls every day. No, so the predisposition depends, is my answer. Say for I think if a patient's had a DVT in the past, they probably should be discussed with us, and I would tend towards it, particularly if it's an unprovoked one. We are stopping people anticoagulation when they're unprovoked, and I usually write quite a major rant, I don't know if you've ever received my letters, about high-risk situations, and I'm like, in a cast, if they walk in the door of the hospital and stay, you know, and this sort of thing. So I would actually be quite aggressive about it, to be honest. And you can get, I mean, a lot of these will only need anticoagulation till they come out of it, and only need prophylaxis. And we are trending towards using dabigatran in the 220 once a day dose, which is the prophylactic dose, if they don't like to inject. So my answer would be yes. If there's any queries, you know, if I think if they've had a clot, it's a pretty no-brainer. If you start talking about, you know, a family history of clotting, or God forbid, someone who's been diagnosed with factor V Leiden with no history whatsoever, you know, someone ticked the box somewhere, you know, then that's a little bit more difficult because of you're sort of talking about risk of clot versus risk of bleeding in these patients. But yeah, my answer would be yeah. If they've had a clot before, I would be quite aggressive about it.
Nicola, would you like to talk briefly about who you would give prophylactic cover for?
In this situation,
Yeah.
or just generally?
Yeah, just this one.
Oh, okay. So I mean, if they've had a clot before, basically, I think if they've had a significant clot, if you look at the guidelines, it's about if they're high risk, and the high risk patients are, you know, previous DVT, the high risk thrombophilias. So if I've got a family with 3. The father we diagnosed with antithrombin deficiency, and 3 boys have got it as well, and their chances of getting a clot are extremely high. So I would prophylax those as well. So the high-risk thrombophilias are your antithrombin and your protein CNS, not so much the genetic ones. I think cancer is a terrible risk factor for clotting, and I don't know if any of your metastatic bowel cancers will be running around, but if they ruptured their Achilles and were in a cast, I would certainly prophylax them as well. I think cancer is one of the bigger risk factors that we deal with. Pregnancy? Yeah, Claire McClintock sort of deals with that a bit more, but one of my colleagues actually broke her metatarsal and was in a moon boot during her pregnancy, and Claire prophylaxed her. I might have been because it had been really embarrassing if a haematologist got a clot, but she did actually get, I mean, pregnancy again is one of those high-risk situations. There's some very good guidelines that the Australian-New Zealand College of O&G did on who you anticoagulate during pregnancy, and I've actually got a copy of those in my bag, and I whip those out every time someone asks me about this, but they're quite good, and they cover all this sort of thing and all about the anti and postpartum prophylaxis. Yeah. Yeah, I mean, aspirin is, so the evidence that we've got for aspirin, again, I've read this, we roll our eyeballs about the surgeons who put patients on 100 milligrams of aspirin after their knee joint replacement, and then they come off their clot. On the other side, as I say to the patients, I can understand the surgeons, because bleeding into your knee joint replacement is a devastating thing, and I never, diss the surgeons, because it's this balance that we're talking about again. However, if you look at the actual trials, and Paul Ockleford always goes on about this, there's some, and they use really high dose aspirin, not 100 milligrams. They were using 300 BD in some of the orthopaedic trials, and I think there was one where they used 160 milligrams, but still it's much higher than what they actually use. And actually, again in this ACCP guidelines, they said it's a very, very slight improvement using aspirin in these patients. And again, it's a lot of patients needed to treat to prevent. On my other side of things, if they're high risk and they'll take nothing else, there's no evidence, but sometimes I stick patients on things, explaining that I'm just doing it because scientifically it sounds good, evidence not so much. Yeah. Depends on the patient as well. So obviously when dabigatran was, or dabigatran, potato, tomato, was introduced, we all embraced it, and there were a lot of issues, but I think we're a lot better about using it now, and we do use it quite a bit over warfarin. We use warfarin obviously in the patients with borderline renal function, and it's really important to estimate your creatinine clearance, not just the creatinine that's on the blood test report. And in the elderly we go for warfarin obviously a lot more as well. They say if you're really lightweight, also there's an increased risk of bleeding. But we do actually offer dabigatran up front to a lot of patients. I think it was about 15% in the trials got the reflux with it, and so we do warn them about the reflux, and some patients do stop because of that. But often if we give them omeprazole as well, they actually tolerate it. And again, if we were just talking about these patients, it's actually quite short term, so I'd probably go with dabigatran if I could. Obviously, you know your patients. Lining up for an INR in the morning when you're trying to get to work, adjusting the doses is actually really difficult for people who get these clots, which are often that young people in the workforce.
Yes.
Yeah. So this is for the actual prophylactic dose is 220 once a day, and actually that's probably quite good. You can actually do it once a day, quite good, because I mean my patients find twice daily taking it long term quite difficult. They try and they said, so you can actually do it just the once a day. That is the actual dose they used in the trials. Some patients prefer to split it, 110 BD. I'm okay with that as well, but actually once a day is the dose we tell people with food. So in the it's till they're out, till they're mobile basically. So we get our nurses to ring them up every so often to find out what's happening in terms till they're out of their moon boot and mobilising. If it's a small clot, we actually don't re-ultrasound it, by the way, either. If they're asymptomatic, we don't necessarily re-ultrasound once the diagnostic one's done.
So, in summary regarding the treatment, if the ultrasound shows that below knee or at or below knee DVT,
Yep.
do you advocate in this group of people that they are treated? Or in actually pretty much anyone who has one?
Yeah. So this is a bit of the debate, isn't it? I mean, if you're in the UK, they actually only scan down to the trifurcation. They actually don't diagnose in some areas the distal DVTs, even though they can be quite painful. And perhaps in different departments, people do different things. But we tend to just treat them, to be honest. We've had clots extend when we haven't. The really interesting thing is Eileen Merriman, who works at North Shore Hospital, is doing a trial called Twister. I don't know if any of your patients have been on that. Now, it's not so much for these patients, but and what she's looking at is really short course anticoagulation for distal DVTs of 2 weeks. So we can do that in patients who get out of their moon boots. But if you're immobilised, we tend to treat them till then. We tend to treat the clot. Occasionally, if it's a 2.5 centimetre posterior tibial, one of the paired, you know, the usual, we'll actually just give them prophylaxis rather than treatment. So we do adjust depending on how symptomatic they are and the size of the clot. Oh. Yeah, Clexane or the dabigatran, really. So the 40 milligrams of Clexane, which we, special authority, we use that one, you know, when you're going to bridge to oral anticoagulation, which gives them a month's worth. Yeah.
The other question I want to ask was, so in the end, your paper, are you saying they had a minimum of 1 week of cast or immobilisation? Is that it? So they could have actually had 6 weeks, we don't know?
That's right. I didn't collect that information. The inclusion criteria was as simple as possible, and 1 week actually fits with the other studies done. That's why I used it. So just in deference to my colleagues.
So we've no idea what percentage have got DVT at 1 week, so they only had the immobilisation 1 week. See, that's what's quite frightening. They only had the immobilisation 1 week, and it would be nice to know what percentage of your...
You got it after there.
There's a graph which shows when it occurred.
Or when it was diagnosed.
When it,
was
yes, when it was diagnosed.
Yeah.
Oh, sorry, did I miss that?
I'll bring it back.
But they could have had it from a week, but not presented till later, unfortunately.
This chap here shows when it occurred from the date of
Or when it was
immobilisation.
diagnosed.
When it was diagnosed. Thank you.
Diagnosed.
Yeah.
No.
That's right, yes, and it's only diagnosed when they complain too. And we didn't go looking at everyone because it's too expensive to scan everyone, so we don't know about the asymptomatic occurrence of DVT.
Yeah. Well, they say it's around 20% is supposed to, I think, but we actually, you know, and I think it's about that, yeah. So that's kind of why we treat them. The other reason we treat them is because of bringing them back for an ultrasound is actually quite difficult in the hospital system. And I must admit, we have liaised with GPs who actually don't want to treat the patient, and they organise another POAC ultrasound for follow-up as well. In the Twister trial, we were actually routinely ultrasounding them, and I think we have about 54 patients who, remember, only had that 2 weeks of treatment, and they never kind of went on at all, but they had a little bit of treatment. Yeah.
Is it likely that the product guidelines may change in the future to kind of swerve away from warfarin use and looking at the newer anticoagulants?
So, to be perfectly frank, I don't know what the POAC guidelines are. I get called about it occasionally, or the nurses talk to us, and I say that sounds very appropriate. I'm not actually sure. Does it say they have to be put on warfarin afterwards? Oh, God. Oh. Yeah, the usual thing, yeah. Oh, that's completely hopeless. You know, I'll talk to the... sorry, that's terrible. No, I'll talk to... Yeah. No, but we should actually change it. I'll talk to...
That's good.
Yeah. I'll talk to Tracy, the nurse. I think there's a nurse lead who does it all, and I'll email her and ask her about it, because no, I mean, yeah. We still use warfarin, but certainly not as much, and I don't think you should be boxed into using warfarin, particularly for these type of patients. Yeah.
That's a very good point. Thank you for that.
Yeah.
Sorry, I haven't actually come across a patient with DVT, someone who's ruptured Achilles, but how do you, so when you suspect it, you take them out of the cast, you do the ultrasound, and then do you put it back in the cast for treatment?
Yeah, we do.
Yeah. Yeah.
That's exactly what happens.
Often.
Can you tell me what that is? A cam walker? This is like a range walker. Ah, right.
Yeah.
Okay.
And if we know someone's going to have a problem, we can put them in the cast and go straight to them.
So what's the statement being made is that after DVT and Dunedin, you get a cam walker, not a cast. You don't go back in a cast. Is that right?
You don't go back to the cast.
Right.
To be frank, we don't really care what you do with them after. We anticoagulate them. Remember, we let you keep them on the oral contraceptive pill with anticoagulation. I think anticoagulation sort of overcomes a lot of the problems. Yeah, yeah.
Just a comment that I assume, just this point, I assume all those patients had symptoms before you actually scanned them.
Yes, they complained. We did something about it.
I just wonder if you were to scan every patient 10 days after a Achilles, how many would actually have a shot?
That has been done, and again, the amount of clots found varies, but can be, it was thought to be as high as 30%. Some have found 40%. Asymptomatic, a lot of them, I guess.
It comes at choosing license.
Yeah. All the ACCP guidelines, in fact, they specifically say they advise against routine scanning after hip and knee joint replacement. Remember, most of them go away again, the little ones. We get loads of little tiny segmental and subsegmental PEs when people are scanned their chest for pneumonia and so forth. We're like, and we kind of have to treat them, but I think finding them is unusual, is one of those things.
So the POAC guideline for the management of DVT in Auckland, low molecular weight heparin for 5 days, then start dabigatran. So that's online. So your area may be different. Warfarin is not first line in Auckland's health pathways. Yeah. So it has been changed. Oh, there
Do
it
we
is.
say as long as they fulfil the guidelines, like the kidneys aren't stuff?
Yeah. They, as per, yeah, exactly.
Yeah, appropriate.
Yeah. So it is changed.
So the Auckland guidelines are probably okay.
I think they're regional, aren't they?
Seems so, yes.
Yeah.
If there are no more questions, I'd just like to make the point that if someone asks you, so people outside of Auckland, if someone asks you for study participants in a dabigatran trial involving tender Achilles, please say yes.
Yeah. And I guess the other thing I'd like to say is we don't mind being rung up at the hospital. Our nurse specialists are actually really good as well. In fact, it's probably easier to ring our nurse specialist in the thrombosis unit in Auckland rather than ringing the registrars. They know more about it and they'll ring us and get back to you probably a bit quicker than the registrar. But I think we do quite a lot of kind of care with the GPs, and with tiny clots we're quite happy for you to look after them. We'll see them if you want us to, though.
Thank you very much.